We also realized from that report.
It's a bit of a hiccup there. All right, yes, as we take a look at the numbers and we try to get a hold of Dorothy once more, that was a bit of a technical hitch. But remember, the conversation revolves around maternal health care. At this particular time, the numbers and mortality rate are, taking highs. And of course, the conversation has been ongoing, not just in the country, but across the global fraternity towards ensuring that the babies and the mummies are safe, especially at that point of birth. Every other time cases being recorded, every other time mothers go out there to give birth, the situation is not always as friendly, but so much has been done. Lots of strides have been made towards making this a successful procedure, towards reducing the number of mortality cases in the country, and that's what we are discussing. And we take a look at the availability of commodities, the availability and affordability of SRHC. And in our hospitals across, not just in Nairobi, but in different parts of the country. Amid all this, we know that very well that donors have been instrumental towards ensuring that we have access to these commodities. But just how much are the mothers able to get them? Just how much are the babies able to get them? Because this comes in handy towards ensuring that their lives are saved. So that is a conversation that we are having this morning, and we welcome you to be part and parcel of it. Hashtag Morning Cafe at Linda_Lela. The numbers to text and call are running down on your screen. Important that you are part and parcel of the conversation. And we have Dorothy back. And yes, Dorothy, we come back to you. Apologies for that hitch.
Sorry. Sorry, technological issues. Sometimes they let us down, you know. Yes, so I was talking about what now inspired us to do the research that we are doing, because most of the women are dying from postpartum hemorrhage and preeclampsia, we need to establish why this is the case. And that is why over the last 4 years, we did a study to look at availability, affordability of sexual and reproductive health commodities for maternal, newborn and child, and STI infection. And of course, the findings that we discovered were actually really matching to what the Ministry of Health itself found out. Yeah. That number one, these commodities are not available. And you can imagine magnesium sulfate, which is used for treating postpartum hemorrhage, costs about 7 to 12 days of wages. So you can imagine a government worker who is on minimum wage. They will need to work for 12 full days to be able for their wife to be able to get treatment for postpartum hemorrhage.
And just hold it right there. Just hold it right there. Over time in this profession, we have been addressing this for the longest of time. I have attended, sessions every other time where the global fraternity comes together towards ensuring that they address maternal health, the cases of mortality and the rise, and try to reduce this. Same has been applied in the country, and we've seen numerous campaigns towards addressing this. Would you confidently say then that really, overall, we've not seen any improvement?
Honestly, I think there's been very little improvement. As you know, we are very good at policies. We have a lot of policies for everything, but having that commitment to translate those policies into action is where we always fall short. So as much as you have a policy that requires that a health facility should have X amount of commodities for women, number one, we don't even equip the lower level facilities. Level 2 and 3 facilities do not have the equipment, do not have the personnel, do not have the medicines they need to save a life. And this is the biggest problem, to be honest.
But what gets us to this point where we do not have enough, we do not have enough for, stock for our very own mothers and own children. And this is not just on matters maternal health. I know it cuts across lots of issues like contraceptives. We talk about, newborn health commodities. We talk about, mental health commodities, cuts across. The question then would be, what informs this shortage? And knowing very well that we've equally seen lots of donors coming on board towards donating these commodities so at least they can be shared far and wide.
Yes. In fact, we have interrogated the results and engaged with the counties where we've conducted this study, and most of them actually attribute one of the biggest problems to issues of the supply chain. Of course, supply chain really is directly talking about KEMSA.
Yeah.
Because we all know KEMSA is the sole distributor of medical products and devices for the public health sector. And so they say that, number one, sometimes when they order, KEMSA doesn't deliver when they're supposed to deliver, number one. Or number two, they don't deliver the quantities according to what they ordered. Or number three, KEMSA themselves don't even have those commodities in the first instance. And because of limitations of purchasing from other sources, then that becomes an inherent problem. But of course, also looking inwards, introspecting, counties also themselves do not allocate enough resources as well. So if you allocate less than enough, then of course you're going to run out of these commodities, as soon as you've purchased them.
This culminates. This culminates to the counties. Do you suppose then the governors are justified to say that, they should probably cut the contract with KEMSA, or maybe not have KEMSA as the sole distributor of these to the level of the counties?
I absolutely agree with that. And if I just join the KEMSA conversation, if it really turns out that some of their prices are also inflated, I think it's only fair that the market is opened up, it's liberalized, we support a lot more local production, and the counties have options of where they can effectively and affordably purchase these commodities.
We'll be blind to, or we would be ignorant to say that, the donors equally do not have interest. If at all this is not executed as per their expectations, don't you think then it will pull us to that point whereby the donors will exit the stage? And some of them have already started exiting the stage. So where does it place us, towards the fight of ensuring that we get, proper health, universal health in totality?
Yeah, I think it's a matter of prioritization, honestly. The counties need to plan effectively. They need to use data and evidence to inform the decisions they make, primarily around budget and budget allocations, obviously. They need to be prudent in terms of how they spend their money. And I think in terms of health, they also need to move away from health infrastructure to actually making the infrastructure put in place to be functional. Because there are many health centers and facilities that have been built across the different counties, but they're not equipped, honestly. They don't even have human resources for health. They don't have commodities. They don't have equipment. What is the point? I think we really need to equip these facilities and make sure that people are able to access facilities at the lowest level. Yes.
It's okay.
Yes. No, I was going to say that when you look at the report I referenced,
right,
most of the maternal deaths occurred between 5 p.m. to 8 a.m. What does this tell you?
Okay.
That the only health facilities that were available to them are the ones closest to their homes, which means these are the lower level ones. And then again, 50% of the deaths were referrals, which also exactly says what I'm saying. They were referrals because there were complications, because the level 3 and 2 were not well equipped to handle a maternal emergency.
All right. So how high or low is the risk of stockouts in your own capacity? Like you've said rightfully there, probably that's the reason why we lose most of the lives. But it is perennial, and you said you've gone through, over to different parts of the country. What, first of all, informs this, genuinely informs the stockouts? Because KEMSA will tell you that sometimes some of this medicine or some of these commodities are dispatched to the levels of the counties, but honestly, they just do not reach the facilities.
Yes, and the responsibility for them to reach the facility still is on KEMSA, actually. Apart from those commodities for contraceptives that are donated by donors, then the counties need to put in a budget for logistics to supply these commodities. But it really is a cocktail of different things. It's a cocktail of inadequate budgeting for these commodities. It's an issue of poor infrastructure for obvious reasons. I remember 2 months ago, we went to a facility in Narok County who told us that they only get commodities supply once a year. And that was really heartbreaking. How can a facility, a level 3 facility, only get commodities supplied once a year? Honestly, it beats any logic and common sense. Right. So it really is prioritization and budget issues as well.
All right. Yes. Even before we get to what would be the recommendations, pawn availability, there's been that argument that clients have been seen to be reluctant to access the SRHC. And they'll be reluctant to access some of these commodities. I mean, even being told that, okay, this is recommended for you, they still are reluctant to go out there and have them. What really informs this, and what are the dangers of the same?
Absolutely, that is absolutely correct, and that is what we found out from the study as well. Yeah. Many people, especially in the rural communities, are not aware that they're supposed to be having health-seeking behaviors, so that when they are not feeling well, they go to a facility to get treatment, number one. But then there are also a lot of myths and misconceptions around the use of contraceptives, to be honest. And that is why, like in the rural communities in Kakamega County, you find, women giving birth every other year. They have even 10 children. But because they have been told that if you use a contraceptive, you'll become sterile and all those things. So I think in terms of provision of services and commodities, this has to go hand in hand with education. We need to educate our women, and we need to particularly educate our girls, honestly. I think we can't really run away from the issue of teenage and underage pregnancies. We really need to provide information to these young girls so that they know what to do and know not what to do, and protect themselves so that they can finish their education.
All right, yes. Let's come to recommendation. So, and maybe, charting the way forward, because clearly then there is a problem, and the problem has to be addressed, having, done a research and, noted, diagnosed, or so to speak. So what healthcare recommendations are there to address the access challenges?
Yeah, of course, the one and the biggest recommendation is improving of the supply chain. First, we need to have the county pharmacists or the persons in the county that do quantification to actually do the correct quantification. So quantification is making sure that you actually know the commodity needs in the whole county, so that when you're ordering enough for each and every one of those facilities to get the commodities they need. Number two, they also need to get a lot of data and evidence that supports their purchasing needs. For example, there is no need for them to buy a lot of female condoms when very few people use female condoms, but probably need Septrin, for example. So there needs to be evidence that informs how purchases are done. There also needs to be continuous training of healthcare workers. One of the reasons that was given for people to be reluctant to go to the facility is because of poor customer care. Some women actually opt to use traditional birth attendants to give birth at home because they say when they go to the facility, the health workers are very rude, They don't take care of themselves and they blame them, so they'd rather stay at home. And this is an issue that has also been given for youths not being able to access information or commodities. And that is why another recommendation we make is that we need to have functional youth-friendly centers or youth-friendly corners where our teenagers and youth can feel very free to walk there at any time to get information, to get services, so that we can really take care of them and make sure that the teenage pregnancy and the cases of STI infections are actually dramatically reduced. Of course, an obvious one is, improving the infrastructure in most counties. You can imagine a county like Kakamega is very vast. You'll be very surprised that there are areas that you cannot actually reach without a vehicle. I mean, the same goes for counties like Kwale, Narok. There are facilities, Isiolo County, facilities that are so far away, in fact, 200 to 300 kilometers away without any transport. So how is anybody living in that locality supposed to access healthcare? So improving infrastructure is yet another recommendation. And then, of course, another thing that has been neglected is, of course, male partner involvement. Many times when we are dealing with issues of maternal and child and newborn health, we actually implement strategies to the exclusion of men. And yet they were part and parcel of, making these children come to be, or making these women pregnant for that matter. So I think they really need to be educated and involved in this journey so that they can be supportive companions and partners as the women are either giving birth, taking the children for antenatal, or that kind of thing. So generally, those are the recommendations. And of course, we need to have policies that support budget allocation for provision of sexual and reproductive health commodities. Because without a policy, then it's impossible for even the county assembly to allocate those resources.
All right.
Yes.
The myths are, especially at the rural areas, the myths still are vivid, the stigma is still vivid. Just how do you get them from that point where, you know, they acknowledge and they understand that there's need to access some of these commodities, they need to go out there and access, you know, health facilities, because it's pretty much important, because most of the times they would argue that even back then, during the oldest times and everything, they probably did not need all this that is being presented to them, and probably they think that they're being bombarded with too much information, bombarded with too much, you know, health commodities, which to them would sound as though they are a risk. So how do they get them to switch and shift to acknowledging the importance of the changes that have come along?
Yes, so what we normally do is to work really hand in hand with, number one, the counties or community-based organizations that are trusted in the community. Of course, we also use community health volunteers that, you know, the people in the community really trust to pass this information to them. We share with them, you know, stories from other regions of people who are not able to access these commodities, of mothers who died of conditions that could have been prevented or saved, and reasons why they really need to, for example, embrace family planning. You know, they need to really have children that they can comfortably take care of. So I think using community champions, using respected members of the community that are able to effectively talk to these people is a strategy that we have used and that we have actually seen work.
Yeah. And yes. Is there data on, you know, these counties and the dire ones, the worst ones, that has been collected, and what is being done towards addressing this?
Well, you'll be very surprised, to be honest, Linda, when you look at the statistics that we've collected. Nairobi is not even doing that much better, surprisingly. When you look at the levels of, absolutely correct. When you look at the levels of availability and affordability of SRH commodities, you find that Nairobi is actually at 39%. Counties like Isiolo are actually over 50%. So to be honest, it is not even a rural issue in terms of availability. I think it's a prioritization issue, to be honest. So Nairobi is not doing that much better either. And I think there needs to be a lot of advocacy in Nairobi as well to make sure that they are providing enough resources, because for them, I don't think it's an infrastructure issue. I don't think it's a logistics issue. I think it's a prioritization issue.
Is that to say that so much effort had been put towards the marginalized communities for a moment, overlooking these other, you know, counties?
In my opinion, actually, when we look at the study we did last year compared to other years, the counties that were in the pilot for UHC actually did a lot better than other counties. Which really makes me believe that, you know, UHC can actually help in terms of improving access to services and commodities if it is well implemented, because we have seen the evidence. The evidence does show that UHC can improve these indicators and these levels of access. So I'm really hoping that even as the country is rolling out UHC in all the 47 counties, that they are going to do it in a manner that actually improves the health outcomes and the negative maternal indicators and child indicators.
All right. Speaking of UHC, I think it's the sole interest of the government to see to it that this is successfully achieved and implemented, that every other Kenyan is going to get access to, you know, healthcare and proper healthcare for that matter in years to come, that is few years to come. If we are to look at the fact that we're highly dependent on, you know, the bigger brothers, we're highly dependent on donors to sustain our health systems in the country. In the event that they pull out 100%, and even in the event that they do not pull out, do you foresee a scenario where as a country we are charting ways towards ensuring that we are fully stable enough to say that we can confidently cater for our health needs as a country, and, you know, not necessarily depend on any other person to come in or any other country to come in to solve the situation?
Absolutely, absolutely. And honestly, that really is a ticking time bomb. And especially now that most donors are actually encouraging domestic resource mobilization and the journey to self-reliance. as a country, we really need to sit down and see how we can be able to manage our internal affairs. And our most intimate internal affairs obviously are around family planning and contraceptives and maternal health and child health. And so we really need to come up with strategies of how we can manage these health matters by ourselves, because that time is definitely coming. As we know, in previous years, 95% of our contraceptives were donor funding. Those donors are already pulling out. In fact, quite a big number of them have pulled out from financing family planning commodities. And I think that is why even last year we saw a lot of stockouts, a lot of low availability of the long-term methods of contraception. So that means that if we do not plan for this, if we do not provide enough finances for this, we are going to go back 20 years, you know? We are going to have a population explosion that we cannot feed, that we cannot manage. And so we really, really need to sit down as a country and see how to manage our internal affairs, see where we are allocating more money than is not needed, and reallocate those resources to, you know, family planning, to maternal health, to child health, and to, of course, adolescent health, because the future is really for the adolescents and the young people that we have in this country right now.
All this conversation, what we're talking about this morning, squarely falls under the health docket, and I mean a docket that has been barred with lots of controversy, lots of disparities, lots of corruption allegations. I mean, just looking at it on the overview, on the face value, do you suppose then that we still need to hold hope high that indeed these changes are going to be implemented, and I mean these areas that we've touched on that are areas of concern are going to be addressed?
Well, the good news, I think I'll call it the good news, is that the health function is now fully devolved. And so I feel it is so much easier for us to advocate to certain counties, specific counties, using evidence for them to put in place strategies that can help their people. I would, for example, specifically talk about Kisumu County, where we've worked over the last 4 years. We have presented them with this data. And I must say that even though Kisumu County is always in the news for wrong reasons of health worker unrest, they have actually, the health ministry in Kisumu has really worked hand in hand with the county assembly, specifically the Committee on Health and Budget. And honestly, in the last couple of years, I've seen a lot of developmental policies, progressive policies that have been enacted, that have been put in place, and accompanying budgets for that. Kisumu County, I think, is one of the only few counties that have a youth-costed empowerment plan that includes issues of youth and teenage sexual and reproductive health matters. And so I feel the fact that health is devolved, I think it is so much easier to hold those health officials at the county level accountable.
Hold it right there. Hold it right there. Let me ask this question. We've had conversations for the longest of time, and many have argued that, including the health officials themselves, have argued that maybe it wasn't wise to devolve the health docket. If these conversations continue to be louder and louder, then probably a reverse of the same would be thought of. Having a health commission is something that would be considered. Do you suppose then that it will have a detrimental effect on the strides that are being made?
Well, I really understand where the sentiments of health not being devolved are coming from. In my personal opinion, I feel the manner in which it was devolved was the problem, because I feel there was really no handover. Just one day an announcement was just made that health is devolved. National government will deal with policy level, counties will deal with service provision without any handover, without any mentoring and all that. And I feel personally that is where the problem really is. But I really feel that health is better placed at the county level, where they are able to tailor-make their health needs based on the specific issues that are afflicting people in that county. You know, the health issues that affect people in Kisumu are very different from those that affect people in Mandera. So I don't think we should have a one-fits-all kind of policy in terms of health. Let each county look at what their issues are, what their needs are, and really work towards meeting those needs, meeting those issues, budgeting for those issues, and making sure that there's an improvement every year in terms of providing services and commodities to their people.
It's always helpful to have a conversation backed by data and, you know, having a research conducted revolving around the same aspect. Thank you so much for the great insights, Dorothy. We only have like a minute or so to wind up. So in 30 seconds, what would be your parting shots?
My parting shot is that health is an issue for all of us. We cannot leave it to the county government alone. We cannot leave it to national government. We cannot leave it to civil society. Neither can we leave it to donors. We need a multi-stakeholder approach where we all come together. We interrogate the issues. We look at the data. We plan together, and we see how we can address the issues that are affecting our mothers, particularly our young women, our mothers who are giving birth, because no woman should ever die giving life. It is an abomination and it should never happen. No child under 10 should be pregnant. That's another abomination. So we need to come together. We need to work together. We need to improve these negative indicators. We need to make sure everybody everywhere has access to all the services and health commodities they need when they need them. And it is all possible.
All right. Wow. Amazing. Dorothy Okebo, CEO, Access to Medicine's platform. Thank you so much for the great insights. I'm sure we're going to have more and more of these conversations. Like we said, it's not just about maternal health. There's more to it when we're talking about access to medicine. Thank you so much. And that's where we get to wind up this session this morning, and also you back at home for keeping us company from the start up until now. We get to see you again later in the afternoon on Newsfeed. My name is Linda Alela. It was great having you. Bye-bye.